So the learning objectives today for you is most importantly to understand the concept of significant bacteriuria, state the etiology of UTI, discuss the pathogenesis and epidemiology of UTI, and acquire knowledge about collection, transport, and processing of urine sample for culture. So before I actually start with this, an orientation to the terms that are used in this. You will come across the term bacteriuria, which means the presence of bacteria in urine. Then there's a term called significant bacteriuria, which means the number of bacteria being more than or equal to 10 power 5 bacteria per ml of urine. This is taken with the assumption that if at all there are some contaminants, the counts do not exceed 10 power 3 bacteria per ml. And then you come across a term called asymptomatic bacteriuria, where there is bacteria in urine, but the patient has no symptoms. The other terms that you will come across regarding urinary tract infection are the lower and the upper urinary tract infection. When we talk of the lower urinary tract infection, we are talking about cystitis. And then it could be either involving both the upper and the lower tracts. So cystitis clinically presents as dysuria, frequency, urgency, and occasionally suprapubic tenderness. Whereas pyelonephritis presents as flank pain or tenderness or both, and fever often associated with dysuria, frequency, and urgency. Now, UTI can either be uncomplicated or complicated UTI. Uncomplicated UTI refers to infection in a structurally and neurologically normal urinary tract, while complicated UTI refers to infection in a urinary tract with functional or structural abnormalities, including those with catheters and calculi. Remember that in general, infection in hospitalized patients and infection involving upper tract is considered as complicated. And the implications are that in these cases, the infecting organisms are more likely to be resistant to antimicrobials. Another term that you come across is recurrent UTI. Now, the recurrent UTI can either be relapse or reinfection. When we talk of relapse, it is the recurrence of bacteria with the same infecting microorganism that was present before therapy was started. While reinfection is a new infection. It may also occur with the same organism and can be mistaken for relapse. Now coming to the etiology of urinary tract infections. Remember that UTI is usually caused by single bacterial species. And also remember that anaerobic organisms are a very rare cause of UTI, and urine is not cultured anaerobically as a routine. So etiology depends on whether it is community acquired or it is hospital associated. When we talk of community acquired UTI, the most common organism is Escherichia coli. The others being Proteus, and amongst gram positives you have Staph aureus, Staph epidermidis, and Staph saprophyticus. I have highlighted E. coli and Staph saprophyticus in different colors. E. coli because it is the commonest, and Staph saprophyticus is more based on Western literature. We have not encountered, although there are some parts of India which have reported Staph saprophyticus as a cause of UTI. Now, apart from community acquired, we have what is the hospital associated. Remember that this is the most common nosocomial infection. UTI is the most common nosocomial infection. An etiology of nosocomial UTI includes predominantly gram-negative bacteria like E. coli, Klebsiella, Enterobacter, Pseudomonas, Proteus, Citrobacter, Acinetobacter, and we also have the others like Enterococcus, Staphylococcus, Candida, Cyanobacterium, Uroliticum, rarely. But as you can see, whether it is community acquired or hospital associated, we see E. coli as the commonest. But in hospital associated, you also, in terms of percentage, you will see other gram negative and other organisms also. While when we talk of community acquired, it is predominantly E. coli is the most common cause and forms the biggest percentage. Hospital associated, you also see some amount of polymicrobial infections and of course antibiotic resistant isolates. Coming to the pathogenesis of UTI. So urinary infections occur due to interaction, like in any other infection, interaction between bacterial virulence factors and the host factors. The possible routes by which bacteria can invade and spread within the urinary tract is the ascending and the hematogenous route. Ascending is most common, that is why I have colored it differently. This is simply to show the host parasite interaction where we see that if the virulence factors take over, lead to infection. So UTI may occur either because of the pathogenicity of the organism, the susceptibility of host, or a combination of both the factors. So like I mentioned, it is the ascending route is most common, and we know that epidemiologically UTI is much more common in women than in men, giving support to the importance of ascending infection, primarily because the female urethra is short and in close proximity to vulvar and perianal areas, making contamination likely, and the contaminating organisms which frequently colonize these areas is the E. coli. We do see hematogenous route, uh, infection of the renal parenchyma by blood-borne organism occurs. Kidney is frequently the site of abscesses in patients with Staphylococcus aureus bacteremia or endocarditis or both. But when we talk of the hematogenous route, we usually look at the gram-positive organisms and not the gram-negative bacteria. So coming to the organisms. E. coli is by far the most frequent infecting organism. As I have already showed you, there is a concept of uropathogenic E. coli clones or lineages, which means that only a few serogroups of E. coli. We also call them the early O groups. You need not remember the serogroups. We call them the early O groups, which is O1, O2, O4, O6, just as an example. Okay. So if you can remember uropathogenic E. coli, also called UPEC. You know there are other kinds of E. coli. You must have heard of diarrheogenic E. coli and all. So these are uropathogenic E. coli, which are the early O groups, cause a high proportion. They possess virulence factors that enhance both colonization and invasion, and hence it causes infection. Coming to the different virulence factors. When we look at the virulence factors, we know that uh, they show increased adherence to vaginal and uroepithelial cells. They produce a higher quantity of capsular antigen. Then there's presence of aerobactin, which is an iron chelating protein, which are also called siderophores. You must be familiar with the term siderophores. Then they produce hemolysin, and all uropathogens are able to use urine as the growth medium. Although it is an incomplete growth medium, but certain metabolites they produce allows the growth of the uropathogens. Now, coming to the virulence factor, coming to each of these individually, one is that adherence. and adhesins of uropathogenic E. coli, which are filamentous surface organelles that are pili or fimbriae, and there could also be non-filamentous proteins in the outer membrane. Now, these fimbriae have been characterized. Characterization has been done based on electron microscopy and then RBC agglutination and so many things. And based on these you will come across the different kinds of fimbriae like the P fimbriae, type 1 fimbriae, S, and so many others. Now, P fimbriae are named so because the receptor is a constituent of P blood group antigen complex present in human erythrocytes and uroepithelial cells. So these fimbriae bind to uroepithelial particular receptors, which are glycosphingolipid. And these receptors are distributed throughout the urinary tract, particularly in the kidney. So this adherence is receptor mediated, and these receptors are present throughout the urinary tract. These P fimbriae are frequently present in the uropathogens. They augment virulence by colonizing and producing ascending infections. P. fimbriated E. coli dominate as a cause of pyelonephritis in urosepsis, and limited studies indicate there is potential of development of P. fimbriae containing vaccines, but very preliminary data. So apart from P. fimbriae, there are other fimbriae like the type 1 fimbriae in these E. coli. And these also bind to certain host epithelial receptors, which are glycoproteins. They also bind to other epitopes on secreted glycoproteins. So basically, they bind to different glycoproteins. And the importance of these is, since they bind to the secreted glycoproteins like secretory IgA, urinary mucus, Stam-Horsfeld proteins. So they bind to these and they are not available for binding to the host epithelial receptors. So whenever these levels go down, then the chances of infection increase, particularly when we talk of TH protein in the elderly. When the levels go down, the chances of infection go up. Almost all cystitis causing E. coli strains except type 1 express type 1 fimbriae. So remember that we talked of the P fimbriae, then there are certain type 1 fimbriae. And besides these, there are other fimbriae like type S, type 1C, G, M, S. And this significance of adherence is seen not only in E. coli, significance of adherence is also seen in Proteus, Klebsiella, Staph saprophyticus. Staph saprophyticus adheres significantly better to uroepithelial cells than to Staph aureus and epidermidis. But remember that typical virulence factors may be absent in isolates causing infection in presence of underlying structural abnormalities. So when there are host factors which are weak, then typical virulence factors from the bacteria are not essential. Other characteristics of bacteria that may be important in the production of upper tract infection are factors such as motility, endotoxin, urease production, K antigen, as I have already told you, hemolysin, and aerobacter. So these things also facilitate upper tract. So when we talk of motility, motile bacteria can ascend against the flow of urine, and the presence of endotoxin of GNB has shown to decrease the peristalsis and to possibly contribute to renal parenchymal inflammatory response. Urease production. Urease production is very important in many ways. You know which are the urease producing bacteria. I'm sure you know that. So when we talk of urease production, we are looking at production of ammonia. So when there is ammonia, one ammonia itself will inactivate complement and affect the immunity. The other side is that ammonia causes alkalinity. So what happens when the environment is alkaline? There is precipitation of stones. So these kind of infections can be very difficult. The presence of K antigen protects bacteria from phagocytosis. Hemolysin facilitates tissue invasion and causes renal tubular epithelial and parenchymal cell damage, and possibly making iron available to the E. coli. And aerobactin, as such, is an iron scavenging protein, or the siderophore, that is able to take iron from the host for its own growth. Now, coming to the antibacterial host defenses in the urinary tract, where host is going to protect itself. One is the urine. The extremes of osmolality, the high urea and low pH levels are protected. Urine flow and micturition, which exerts a flushing effect, is also protected. Urinary tract mucosa has fluid secreted by cells containing cationic peptides, provides the surveillance function. The surface mucopolysaccharide and glycosaminoglycan are responsible for natural resistance to adherence. So the host also resists in many ways. Then there are other factors, one of which I already told you, the TAM horseville protein. So this is the most abundant protein of renal origin in urine. And this binds strongly to E. coli that express type 1 and type S fimbriae. So when they bind this, when the E. coli binds to these, then certainly it doesn't bind to the uroepithelial cells. So these are all protective mechanisms. And also secretory IgA again prevents the E. coli from binding to the uroepithelial cells. And there are miscellaneous things like prostatic secretions, the composition of prostatic secretions, which is inhibitory for bacterial growth. That is why in men in aging, when the composition, there is a change in the composition, then there are more chances of infection. Besides these, several abnormalities of urinary tract interfere with its natural resistance to infection. Obstruction is one very important factor. Obstruction which leads to stasis and increased susceptibility to infection. So this obstruction can be either extrarenal or intrarenal, and the most common cause is calculi and benign prostatic hypertrophy, which is seen in men. Furthermore, calculi may develop secondary to infection. I already told you that it is the urea splitting organisms which can lead to the production of stones, the calculi. And it is the vesico-urethral reflex. All these changes, all these abnormalities of the urinary tract interfere with its natural resistance to infection, particularly abnormalities which lead to stasis, which inhibits the normal flow, will lead to automatically to infection. Coming to the epidemiology of UTI, UTI is seen in all age groups, but remember that it is very common in adult female population. And whereas in adult men, the prevalence of UTI is low. When we look at older years, there's a decline in female to male ratio. Obstructive uropathy of the prostate, BPH that we just talked about, and loss of bactericidal activity of prostatic secretions in men leads to increased susceptibility to UTI. On the other hand, it is not, although women in the younger adults, we see UTI very common, and we've already talked of the reasons for that. But in the later age groups too, estrogen deficiency leads to alteration in flora. Alteration in flora would mean loss of lactobacilli. Loss of lactobacilli would mean colonization by gram-negative bacteria in the perineal area and all. So we are looking at estrogen deficiency in elderly women also contributes to UTI. Bacteriuria in patients with other conditions, certainly we see in hospitalized patients. It is very common, not only because of the general ill health, but also because of urinary tract instrumentation, catheterization, and various underlying diseases predispose to UTI, and renal 50% of renal transplant patients develop UTI infections in the post-op period, whether it is the presence of the catheter, whether it is immunosuppression, various factors contribute to it. The risk factors for UTI, briefly to show you that in all ages, I have already talked about it, that in older women it is the estrogen deficiency, and in men it is prostatic enlargement, and in adult females, various factors which can, the lack of hygiene and all can contribute to it, and factors which are common in both, like instrumentation, urological instrumentation, surgery, catheterization, the obstruction due to calculi, renal transplantation. These are common in both men and women. Coming to the laboratory diagnosis of UTI. Remember that amongst all the samples that we receive in the laboratory, urine is the most common type of specimen that arrives. Also remember, we talked of the concept of significant bacteria, but to determine the counts, we use semi-quantitative culture of urine to determine whether it contains potentially pathogenic bacteria in numbers sufficient to identify it as a cause of infection. Why we use semi-quantitative methods? Quantitative methods are very time consuming and not possible to do it for the hundreds of sample you get in the lab. So we have to do it in a way that it is possible to process all the samples. So the best way is to use the semi-quantitative technique. Now, before we actually go on to the sample collection and transportation, etc., for laboratory diagnosis, just a few terms that you may come across: abacterial or sterile pyuria. That is, patients with signs and symptoms of urinary tract sometimes produce samples of urine that show pus cells but do not yield a significant growth of bacteria. That means pus cells positive and bacteria negative. This could be seen in many conditions. One is the patient may be taking antibiotics prescribed on a previous occasion. There may be an infection with an organism that does not grow on media normally used, because normally in bacteriology, as I'll be telling you once I tell you about the sample processing, we use limited number of media and the organism may not be able to grow. So it is also in such cases important to consider genitourinary tuberculosis or gonococcal infection, the infection with nutritionally exacting bacteria. But these it can also be seen in a patient that is overhydrated or in patients where there is an obstruction. Another terminology that you come across is apioric bacteria. That means bacteria are seen while there are no pus cells. This could either be because of an unsterile container or prolonged storage of the sample in inappropriate conditions, which leads to degeneration of pus cells. So these are some of the terms that will be given in your books, and I thought I will tell you these before I go on to the sample collection, transportation and processing. One more thing that is important to understand is the significant bacteria, which is a CAS concept. CAS in 1957 suggested that this number be taken as 10 power 5 bacteria per ml. So the proof that urinary tract infection requires the demonstration that the potential pathogen is present in the voided urine in numbers greater than those likely to result from contamination from urethral meatus and its environments. So to simply put, that we know that normally the urine is sterile, but there would be some amount of bacteria present in the distal urethra. So this bacteria present in distal urethra are likely to contaminate the sample once we are collecting it. But we also know that these bacteria would be in numbers which are low. So, and the maximum that was described at that point was these contaminants cannot be more than 10 power 3 bacteria per ml. So, keeping all these things in mind, CAS suggested that the number for us to take as significant is 10 power 5 bacteria per ml. But remember that in a hospital setting, you cannot take it as a hard and fast rule that if 10 power 5 are not present, then it is insignificant. Because you will see that in the hospital setting, majority of the patients are on antibiotics. So if the patient is on antibiotics, we do not expect those numbers. So we have to treat the patient individually, take each one individually and see where to consider counts as significant. Another important thing, apart from the number, is that when the bacterial species that grow are contaminants, then the counts are not only low, mostly the colonies are variable and diverse. Do you follow? Not only is the count low, but the bacterial species are diverse to distinguish it from contamination as from the significant bacteria. Another very important aspect to remember when we talk of contamination, I will come to it in microscopy. When you are doing urine microscopy, you will see the presence of squamous epithelial cells if the sample is contaminated. So the presence of squamous epithelial cells also indicates that. So these are various things that give us an idea whether the growth that has grown in culture media is of significance or it is just contaminants. Exactly what I was saying some time back, that a rigid adherence to the above guidelines should be avoided and culture count should be interpreted in relation to clinical information from the patients. Indications that scanty bacteria, that means less than 10 power 5, are not merely contaminants are that when we see a pure growth of organisms, that is all or almost all colonies are of same species. We also call this as pure growth of bacteria. The findings on microscopy of pus cells but absence of squamous epithelial cells. This also I told you just now, that if you see pus cells but there is no squamous epithelial cells, it is likely to be significant. The presence of squamous epithelial cells indicates contamination. The specimen has been collected from suprapubic aspiration or freshly inserted urethral catheter. Patient on antimicrobial therapy, which will be the case in almost all the patients who are admitted, and a patient excessively hydrated or on diuretics. So remember that although there is a concept of significant bacteria that was given by CAS, which clearly said that the counts of more or equal to 10 to the power 5 bacteria per ml of urine are to be taken as significant and processed, you have to keep in mind that this is not a hard and fast rule. So you will have to see where to even lower counts are to be taken as significant. Specimen collection is very important. What you do is collect an early morning sample. Why do we prefer an early morning sample? Because the person would not have voided for 4 to 6 hours at least. So you get a sample and the bacteria from there. Another important aspect to remember is that we collect the middle of the stream of urine, the so-called midstream specimen, the MSU specimen. Midstream specimen is collected because you let the initial part, because there may be contaminants in distal urethra, you let that flow and you collect the middle of the stream. So another important thing to be kept in mind when you tell the patient, you give instructions, is a clean catch technique, that you have to clean the area with soap, water, mild detergent, but no antiseptics. And the sample is to be collected in a sterile universal container or any other wide mouth container. So specimen collection, when you give instructions, you have to remember that the specimen has to be collected by a clean catch technique. The middle of the stream is to be collected in a wide mouth container, and preferably the early morning sample is best because you would get sufficient bacteria in that sample. So clean catch technique and middle MSU sample, midstream sample. Transport like any other sample. We always tell you transport to the lab without delay. If it is to be a brief delay, you can also refrigerate the sample. Why do we need to refrigerate the sample? Otherwise, the counts will increase, the bacteria is going to multiply, and you will get false high counts. And you can refrigerate at 4 degrees, the count stays stable for 24 hours, the pathogens remain viable, and contaminants do not overgrow. Alternatively, you can use boric acid at a final concentration of 1.8%. So transportation is very important. Quick transportation. And in case of delay, refrigerate. We refrigerate to keep the count stable. We do not want them to multiply. And we do not want the contaminants to overgrow. Because if they multiply, then the counts can be high. So once it arrives in the laboratory, like every other sample, we do a macroscopic examination and we do a microscopic examination. A macroscopic examination, normally it is the sample is clear and amber colored, but we look for if there is any turbidity or there is any hematuria. Microscopic examination, we do a wet mount, wet preparation. We look for pus cells, bacteria, RBCs, epithelial cells, particularly squamous epithelial cells, any crystals, any yeast cells, any parasites. And we do the microscopic examination without directly on urine. We don't have to centrifuge the urine. And if the presence of one leukocyte per 7 high power field is taken as significant. So when we do a wet mount preparation, our purpose is to look for pus cells, the bacteria, the RBCs, the squamous epithelial cells, the crystals, the yeast, and any parasites if present. So if we see a lot of pus cells and a lot of bacteria, then of course we know the chances are that the patient has UTI. This has other implications also, which I'll come to it later, because in such cases where you know that you are seeing bacteria and you know there are pus cells, you will of course culture urine as we do for every other sample, but you can also put up something called direct sensitivity directly from urine. Although not standardized because you don't know what is the inoculum size and that, but still it helps, and there is a good concordance with the sensitivity that we put up after the subculture, but it helps to save 24 hours, which is a big time. So once you have after the macroscopic examination, one needs to microscopic examination, one needs to culture. So if you want the exact count, then there are methods such as pour plate or Miles and Mishra. But they are so laborious, and imagine if we are getting 150 samples of urine per day. It is not possible to do it. So we use a simpler, quicker method, which is the semi-quantitative method using a calibrated loop. Now, what is this standard loop or the calibrated loop method? Calibrated loop is a calibrated loop which will deliver 0.01 ml or 0.001 ml is used to streak urine on agar plates. After incubation, the number of CFUs is counted and total number of organisms originally present in 1 ml of specimen is estimated by multiplying with 10 power 2 or 10 power 3 depending on the loop size that we have used. So if we have used a loop that holds 0.01 ml of urine, you count the number of colonies and multiply by 10 power 2 to get the count. And if you have used 0.001, then multiply by 10 to the power 3. What are the media that are used for urine culture? We can use blood agar, McConkey agar in combination, or we can use a single medium, which is clad medium. Now, what is this clad medium? Clad medium is cysteine lactose electrolyte deficit medium. So, being electrolyte deficit, it does not allow the swarming of proteus. Clad medium is a differential medium. It will distinguish LF from NLF, just like McConkey. But then why don't we use McConkey? Because McConkey does not allow the growth of many bacteria. This will allow the growth of staph, streptococcus, candida, everything that we possibly expect in urine. So it's a differential medium, just like McConkey. So lactose fermenting are yellow. So what you see here, these yellow colonies are lactose fermenting. So this is from the picture taken in the lab. This is how E. coli looks, since I told you E. coli is the commonest. And NLF appear bluish green, blue or greenish in color. So this is the composition of clade. So it allows the growth of virtually every bacteria that you expect in urine. Of course, I'm not talking of fastidious organisms, which are anyways rare. So this is preferred media to the combination of blood agar and McConkey. And this is what we are using in our laboratory. So semi-quantitative culture, also remember not to centrifuge urine because it will concentrate the contaminants. And as I told you in the beginning, that voided urine is not cultured anaerobically. So it is not that we do anaerobic culture of urine as a routine, and it is never sent for anaerobic culture unless there is suspicion of carcinoma or papilloma of the bladder. There are other methods of semi-quantitative culture which are commercially available, like a dip slide method is a small plastic tray containing a layer of agar. These are commercial things. We are not using them, but more for completion. It is dipped in freshly voided midstream specimen and incubated at 37 for 24 hours. So this temperature and incubation condition holds for all. When we culture on blood agar, McConkey combination or cladanol, we'll incubate at 37 and we will keep it for 24 hours and interpret the growth next morning, count the number of colonies, multiply by the dilution factor depending on the loop size that is used, and then give the counts and also put up the antibiotic sensitivity. So this is dipped and you count the colonies, and commercial suppliers of dip slide provide charts showing representative numbers and patterns for comparison. So basically the process is the same, that you inoculate. Here you use the calibrated loop, you incubate at 37 for 24 hours, next day count the colonies, multiply by the dilution factor and followed by antibiotic sensitivity testing. I also told you when I was telling you about microscopy of urine that there are certain conditions where you can do a primary sensitivity test, and urine is one such sample. So, and primary sensitivity tests are restricted only to those body fluids which are normally expected to be sterile, where you don't expect normal flora. So if you see pus cells, you see bacteria, you can put up directly on the sensitivity plate with antibiotic discs. This simply helps us to cut down the time by 24 hours, and there is very good concordance between the primary sensitivity tests of urine and subculture sensitivity tests. Typing can be done but not done as a routine. It is more for epidemiological purposes where you want to distinguish reinfection of a patient with the new strain and a relapse. One important thing that I wanted to tell you was in the hospital setting, where very often you need to collect urine sample from a catheterized patient. How would you collect urine sample from catheterized? Rule number one is that you should never collect the urine sample from the bag. because it will be nothing but contaminated. So what we do is we normally clamp the catheter for half an hour. You can, put a sterile gauze and clamp the catheter for half an hour, come back in half an hour, and then clean the area of the port with 70% alcohol. Use a sterile syringe and needle to draw whatever 5 to 10 ml of urine and place it in a sterile container. But once you have finished this, also remember to declamp. You need to declamp before you leave. So this is very important on how to collect the urine sample from catheterized patients, because I have seen that many times the residents and are not aware. So this is how is to be collected. An important part is never to collect it from the bag. So uh, so once you have the growth, then we put up antibiotic sensitivity. I have already told you about primary sensitivity. The antibiotics used would be similar, and this is when there is growth, there is a first line drugs, and you can see basically, you can see that fluoroquinolones, cotrimoxazole, and fosfomycin, cephalosporins, these are put at first line, and the second line is largely in the injectable drugs. Then there are certain screening and automated tests for UTI, but uh, they are just presumptive tests. They do not give you a clear-cut idea. Like I have just included it for the purpose of completion, as your books give one grease nitrite test based on the absence of nitrite in normal urine. Because if there are Enterobacteriaceae family, the bacteria of Enterobacteriaceae family, they will uh, reduce nitrates to nitrites. So if nitrites are present, it would be presumptive indication that there is there is a bacteria of Enterobacteriaceae family. Then doing a catalase test or microscopic examination of bacteria and gram films, which is laborious. You can use a leukocyte esterase paper strip indicating of pus cells. Remember that none of these screening methods is as sensitive or as reliable as culture. Culture is the gold standard. There are also some automated methods, but culture on standard media is what we are following. So now just hang on for your attendance.